Welcome to AETCM, the Emergency Medicine channel. I am presenting here a case of a 59-year-old male, Babu, who is hailing from Angola. His occupation is runs a shop, and is from an upper middle class family. His informant is self and son, and information is reliable and adequate. In presenting complaints, his headache, vomiting since one day. His vomiting are 4 to 5 episodes, and his last vomitus contains a blood tinged vomitus 1 episode, and abdominal discomfort since 1 day. And history of presenting illness, 59-year-old male who is a known case of chronic liver disease with portal hypertension, now presented with headache since 1 day. Headache was acute in onset, generally gradually progressing, and experienced throughout the day. It was continuous, dull aching type of pain, felt over the bilateral frontal region, and headache was so severe that the patient couldn't carry out his day-to-day routine activities like going to his shop, and no aggravating or relieving factors, and no visual disturbances, or no aura or lacrimation. Headache was not associated with any weakness of the limbs, numbness or photophobia or phonophobia, and no history of any fever or head trauma.
Headache can be associated with weakness of limbs. What are the conditions? What is there in your mind when you're telling that type of history?
Stroke, icy bleed.
Icy bleed. Okay then.
Migraines and also present.
Hemiplegic migraine. Can paraplegia associated with headache? Hemiplegia is correct. That anyone can tell. As a final year medicine BG, you have to tell me central causes for paraplegia. Which artery involvement can produce paraplegia? AC inhibitor. AC, anterior circulation. Anterior circulation, hemorrhage or stroke. But it has got bilateral connections. What you told is correct, but there is a peculiarity, anatomical variant of ACA can have lower limb weakness. What is it? There is an anatomical variation of ACA. What is that? Unpaired anterior circulation. So from one side, both arteries of ACA are formed sometimes. If that artery is blocked, patient can have frontal lobe, infarct, stroke, bleed, whatever it is. In that case, the presentation will be bilateral lower limb weakness. Okay. But that is very, very rare. Okay. So this is one of the cause for paraplegia, central cause of paraplegia. Okay. Whereas all other causes of paraplegia is mostly associated with bladder involvement. Here it is not involved with bladder.
So headache, in this patient, headache was associated with nausea and vomiting, 4 to 5 episodes of vomiting. And vomitus was mainly contained food particles. And last episode of vomitus, he noticed to have a blood tinged. He noticed to have a bright red streak of blood. And
what it can be? What is that condition called as? Malrivis. Okay. Tear.
No history of abdominal pain, hiccups, weight loss, loss of appetite, or constipation, diarrhea, or melena. He complained of abdominal discomfort since the past 1 day and started after the vomiting episode. He experienced it as a blotting sensation, sometimes associated with a retching also. And no history of any cough, chest pain, palpitation, dyspnea, orthopnea or PND, and syncope, or no history of any decreased urine output, dysuria or giddiness. So he was brought with his complaints to the ER.
Okay.
And coming to the past history, he was diagnosed with a chronic liver disease 6 months back. So it was on December 2023, and hospital admission 3 months back for abdominal discomfort and distension. And no history of significant past history of any chronic diseases like TB, diabetes, hypertension or dyslipidemia, and no significant past surgical histories. And personal history, he was on mixed diet, normal sleep, and disturbed since 1 day due to headache. A normal
what is
appetite.
The importance of diet in CLD patients?
CLD patient should maintain a high protein diet. Low protein diet.
Low protein.
So
can you tell me exactly what type of protein should be restricted in CLD in acute condition and in chronic conditions?
In chronic condition, animal protein should be reduced.
Be avoided. Okay. Avoided. In acute condition? Can we give protein in patients with Acute liver injury in ICU? Yes or no? Huh?
Yes.
Yes.
Protein. Acute hepatic encephalopathy, can we give protein diet?
Uh,
No.
No. So in acute patient with encephalopathy, better avoid all types of protein. But in chronic patient, avoid animal protein.
protein.
They take animal protein, then there is a chance of hepatic encephalopathy in that type of patients. Okay. What potassium diet you advise to the patient?
It's normal potassium, high potassium.
Normal or high? See, all these things are very important. When you are discharging a patient, you should know how to advise the diet. That is the importance.
Yes, avoid hypokalemia.
Hmm? High potassium. You have to give high potassium. If there is no renal failure, high potassium diet is advised in CLD patients. But if there is a renal failure, definitely you have to restrict the potassium.
And there is normal appetite and normal bowel and bladder habits. And he is a personal history. He is an alcoholic since the age of 20 years. For the past 39 years, he was using alcohol and stopped since the past 6 months after diagnosing with
Alcoholic and alcohol intake both are same or different?
Different.
How it is different? Alcoholic means what?
Continuous
daily
daily intake of
Daily intake, if you take 30 ml daily, will you become alcoholic?
patient have to be
60 to 80 gram of alcohol intake.
If you take 60 to 80 gram every day, will you become alcoholic?
dependent on the alcohol.
Then that is alcoholic dependent. What do you mean by alcoholic? It's a psychiatric diagnosis, alcoholic. So that is entirely different from your occasional alcohol intake, dependency, all these things. You should read about what is alcoholic. Okay, then only you should brand somebody as alcoholic. Suppose somebody takes 30 ml alcohol every day, he is not alcoholic. If it affects his public life, and like he told, it is if he is dependent on that, then only we should brand the patient as alcoholic. If somebody takes alcohol 60 ml, he is not addicted to that, he is not creating any problem to public, then he is not alcoholic. Okay, so when you are branding somebody like that, it has to be very clear. Okay.
No smoking or drug abuse history. Coming to the family history, no significant history of chronic illness in the family, no history of any similar disease in the family. And coming to the drug history,
Similar disease means alcohol.
cerebral liver diseases.
What liver diseases run in the family?
Could be hereditary liver diseases like hemochromatosis or Wilson's disease.
Biliary cirrhosis, fatty liver
disease. Drug history, he was on multiple drugs including pantoprazole, lactulose, B complexes, and also thiamine. And also he was on midodrine, and he was on diuretics like spironolactone 50 mg and torsemide 10 mg.
Midodrine is started for what?
He was diagnosed with CLD. So
when you are starting a medicine or when you are telling, you should know all about this medication, why midodrine is started, what is the action of midodrine in portal hypertension, everything you should know. Okay. So read about midodrine, use of midodrine in portal hypertension, chronic liver disease. Okay.
Yes, and immunization history, he was recently vaccinated 2 months back with the influenza vaccine and pneumococcal vaccine and hepatitis B vaccine. And an allergic history, he has no known allergy to drug, dust or food. And general examination, patient is conscious, oriented to time, place and person, cooperative and obeying commands, and no pallor or conjunctiva was congested.
Tell me all the findings of liver failure in a patient. Liver failure, head to toe.
Head to foot examination. Patient can have spiroted enlargement.
Head means hair.
Alopecia can be there.
Alopecia.
And patient can have icterus.
Parotid gland.
Parotid gland enlargement can be there. And coming to the mouth,
smell of
fetor hepaticus.
Okay.
Then coming to the skin,
chest
when it's just loss of chest hair can be there. Spider angiomas can be there.
Okay, spider angioma. Breast
Gynecomastia can be there.
Female.
And female atrophy of the breast.
Breast atrophy. Then
Then coming to the abdominal distension can be there. Loss of abdominal hair. I think can be there. And also
Signs of portal hypertension.
any dilated veins can be caput medusa.
Caput medusa.
Caput medusa.
Okay. Dilated, from the flow of the dilated vein, can you make out whether it is a portal vein obstruction and other conditions?
Yes, if the direction of flow is from below upwards, is due to IVC obstruction. I think, and so from radiating from center to periphery, it would be portal
hypertension. Okay. What position you will examine these patients for getting these veins?
In sitting up and standing position.
Only in standing position. Okay. Then
testicular atrophy can be there.
Okay.
And loss of pubic hair and axillary hair can be there. And
what is the sign of testicular atrophy?
The loss of testicular sensation.
Okay. Then.
And coming to the palms, redness of the palm, palmar erythema can be present, and Dupuytren contractures can be there in palms. And nails, the white nails can be leukonychia can be present. And
peripheral nerves. What findings you get in alcoholic?
Peripheral neuropathy.
Okay. Continue. So you have to look for all these findings when you are examining a patient.
And this patient had icterus was present, and no cyanosis, clubbing or lymphedema, and bilateral pitting pedal edema was present. And head to foot examination in this patient, generalized pigmentation of skin was present with alopecia of the skin over the bilateral lower limbs and axilla and chest regions, and yellowish discoloration of nails was present, and gynecomastia was present, and thyroid was normal, and thickening of palmar fascia of bilateral palms.
Define gynecomastia.
As a subareolar nodule can be felt with more than 2 centimeter
lump.
Okay.
Breast enlargement is not gynecomastia. Okay. Suppose you get a patient with gynecomastia without liver disease, which organ you will examine? Male patient is coming with gynecomastia. Young male patient is coming with gynecomastia. Which organ involvement do you suspect there? What all organs involvement can be there? One is breast itself. Patient can have gynecomastia because of the growing age. Then patient can have breast malignancies. But sometimes unilateral painful gynecomastia is a feature of, or bilateral also. Painful gynecomastia is a feature of. In male, which organ you will examine? This is not an emergency medicine question, since he is a medicine BD I am asking. Testis is the most important organ you have to examine when there is a young male coming with gynecomastia, that too painful gynecomastia. Okay.
Coming to the vital signs, pulse rate was 76 per minute, regular rhythm, normal volume and normal character, no thickening of vessel wall.
Bradycardia with jaundice is a feature of? Bradycardia with jaundice is a feature of? Obstructive jaundice.
And no thickening of vessel wall, and all peripheral pulses were palpable bilaterally. And blood pressure was 110/70 mm mercury, right arm, measured in right arm in sitting position, and respiratory rate of 16 per minute, regular and abdominal thoracic, and temperature was 98.6 degree Fahrenheit, and axillary temperature was noted, and the saturation was 97% in room air. Come to systemic examination, examination of upper GI tract, oral cavity, lips and gums were normal, teeth there was yellowish staining was present, and oral mucosa, aphthous ulcers were noted, and tongue was normal, tonsil, fauces and palate were normal, a posterior pharyngeal wall was normal, and no halitosis was noted. And esophageal function was, he was able to swallow both solid and liquids. And examination of lower GI tract, inspection, abdomen was slightly distended but flanks were full, umbilicus was normal, and all quadrants of abdomen moves equally with respiration, no visible scars, sinuses or dilated veins, no visible peristalsis and no divarification of recti. And palpation, superficial palpation, abdomen is soft and distended, and no local rise of temperature or guarding or rigidity or tenderness, no palpable mass or pulsations felt. And deep palpation, spleen and liver were not palpable, and kidney was also not palpable, no rebound tenderness, abdominal girth was around 104 cm, and dipping palpation was normal.
What is TROPS percussion? TROPS area percussion?
TROPS area percussion is used to feign splenic enlargement.
Which is TROPS area?
Dropsy area is superiorly medially by left inferior costal margin and laterally by the mid axillary line, and found by the superiorly found by the apex of the junction meeting point of mid axillary line and superior costal margin, and
That is
inferiorly by
full
the
in which all
axis.
conditions?
This can be full in splenic enlargement, and also if the stomach, if it's a full stomach,
Full stomach, spleen, and left-sided
pleural effusion,
pericardial effusion.
pericardial. Percussion, the upper border of liver percussed at the right fifth intercostal space in the midclavicular line, and lower border of liver was actually percussed, and liver span was around 12 centimeters.
Normal liver span is?
That's 8 to 12 centimeters.
So it is only 12,
12.
and you are telling it is chronic liver disease. What will happen to the liver in chronic liver disease?
Liver can be shrunken, sir.
Okay. Initially, when there is an
it can be
inflammation, it can be increased,
enlarged.
and normally after some time it will be shrunken.
Shrunken.
Okay.
And spleen, the trough size was resonance, sir.
Okay.
And no shifting dullness or fluid thrill noted, and puddle sign was not performed.
Okay.
And flanks showed a dull note on percussion, sir. And the renal angle was resonant. And auscultation, bowel sounds heard normally, and no brewy, hepatic or splenic rub or venous hum noted. External genital and hernial orifices were normal, sir. And rectal examination was not done.
Okay.
And other system examination, the higher mental function was normal. CNS higher mental function was normal.
Why rectal examination is important in CLD? It is not done in many patients, but is it important, and can you make out some finding from that?
Yes, sir.
What finding?
Lower GA.
So you can get lot of like what you see in varices, you can get lot of veins there. Okay. So that is one of the findings seen in CLD patients, but it may not be very useful in routine clinical practice. Okay.
CNS higher mental function was normal. Cranial nerve, pupils, bilateral 2.5 mm equal and reacting to light. And extraocular movements were normal, no nystagmus, and other cranial nerves were also normal. And motor examination, bulk normal.
What will be the earliest clinical finding in hepatic encephalopathy in neurology?
Neurology, there will be altered sleep patterns.
Okay. Altered sleep pattern. What finding you on examination you will check? Asterisks. That is for emergency medicine. They should know more. Huh?
Patient will be confused. Mild confusion can be.
Doctor also will be confused. It is not that. See, you ask the patient to button. Constructive apraxia is one of the earliest findings seen in liver disease. Construction apraxia, how will you check? How will you check construction apraxia? Huh?
Unbutton and button.
Unbutton and button is the most easiest thing. Other one is with matchsticks. Okay, you show some pattern and ask the patient to do it. Okay, but we don't do all these things because in emergency room it is not practical. But you have to do all these things. What?
Clock test.
Clock test. Okay, so all these things are very important. You have to do it.
Yes, sir.
Okay.
At motor, bulk normal, tone was normal, power 5/5 in both upper limb and lower limb. Reflexes, deep tendon reflexes 1+, both upper limb and lower limb. Plantar were flexor, and sensory was normal. Cerebellar signs were negative. Gait was normal. Skull and spine was normal. And cardiovascular system,
What cerebellar involvement can be there in alcoholics? We have seen one case last time. Cerebellitis. Chronic cerebellitis is a feature of chronic alcoholism. It's a toxic mediated problem. Okay.
Cardiovascular system, JVP was not elevated. Apex beat was palpated, left fifth intercostal space, medial to midclavicular line. And S1, S2 was normal intensity and no murmurs were heard. Respiratory system, upper respiratory tract, nose and paranasal sinus were normal. Lower respiratory tract, trachea was central. Respiratory movements normal. Normal vesicular
What
breath
clinical
sounds.
finding you get in respiratory system in chronic liver disease?
Can be pleural effusion.
Pleural effusion is the most common finding, especially on which side?
Right side.
Right side. Then next important finding. What is the next important finding seen in chronic liver disease, ascites? Pleural effusion is the most common finding. Then hepatopulmonary syndrome. What is that? So many times we have discussed that. Hepatopulmonary syndrome. What is that?
Orthodeoxy.
Orthodeoxy. What is that? It is because of shunt formation in the lungs. Okay. So that is also terminal event of the chronic liver disease like hepatorenal syndrome, hepatopulmonary syndrome. Okay. All these things we can see in patients who is having CLD. And what will happen to the diaphragm? What happened to the diaphragm in severe ascites?
Pushed up.
It will be pushed up. So lung area will be reduced. Okay.
To summarize the case.
Okay.
59-year-old male was known case of decompensated liver disease with portal hypertension. Now presented with complaint of headache, vomiting, and abdominal discomfort since 1 day and 1 episode of hemoptysis. He was having a significant alcohol intake history since 39 years, and on examination, higher mental functions are normal. Icterus was present, bilateral pitting pedal edema was present, and signs of CLD like alopecia of the skin over axilla and chest, gynecomastia, and thickening of palmar fascia bilaterally was present. And vitals were stable, and per abdomen examination revealed distended abdomen with full flanks, and other system examination was within normal limits. We would like to consider a provisional diagnosis of decompensated chronic liver disease with portal hypertension and etiology of alcohol intake, and no signs of hepatic encephalopathy.
What is the clinical evidence of portal hypertension?
In this patient, he already was diagnosed with portal hypertension.
So otherwise, what are the clinical findings of portal hypertension?
Can be dilated veins over the
then
splenomegaly.
Then
And patient can present with history of
GI bleed.
Okay.
Hemorrhoids. Okay, then what will happen to the platelet count in portal hypertension?
Be reduced.
It will be reduced. Reduced due to?
Due to splenic enlargement.
What is the normal platelet destroyed in your spleen every day? Percentage. What is the percentage? In your normal spleen, 30% of your platelets are every day destroyed in your spleen. So if the spleen become double the size of normal, that is more than 13 centimeter, or when you get a palpable spleen, it will be mostly double the size, normal spleen. So what will happen? It will become 60%. So that is normally any patient who is having portal hypertension, spleen will be enlarged. You can see that platelet counts are dropping down. Okay, so a platelet count alone will be enough to make a possible diagnosis of portal hypertension. Even you don't have a facility to do endoscopy. Okay, but here it is not that case. We have endoscopy, we have ultrasound, all clinical modalities to make a diagnosis. But some hospitals we have to depend on these type of investigations. Okay.
Yes. So this was our diagnosis. Later, this patient was actually investigated for this persistent headache.
Okay.
In emergency, it was done. Emergency CT was done. CT brain plane was done, and it was showing a bleed actually.
Okay. Where was the bleed?
It's a right cerebellar bleed, sir, measuring around 5 into 3.5 centimeter.
Okay. Should we admit this case in ICU or in ward? That is very important. So you have a small bleed in the cerebellar area. Should we admit this case in your ICU or ward?
ACM.
Why ICU?
Progressive worsening of sensorium and expansion of worsening of the ICU bleed.
What is the answer? Answer is correct. What is the explanation of that? What he told is also correct. But why we are asking this question? Because this is very important. A small bleed in the anterior compartment, a small bleed in the posterior compartment, both are entirely different. It is because an infratentorial bleed, even if it is very small, the space is very, very small area, and a small bleed itself can increase the pressure in the brain, especially in the brainstem area. They can easily develop honing of the brain. That's why this type of patients we have to keep in ICU. We have to continuously monitor for raised ICP. Whereas this type of small bleed in the anterior compartment may not be significant. Maximum they can have some seizures. Otherwise they may not deteriorate fast. Okay.
And sir, he was admitted under neurosurgery for the patient.
So what was the reason for bleed here?
It could be deranged coagulation profile, sir.
What was the PTINR?
INR was around 2.25, sir.
APTT?
APTT of 45.8.
It's slightly elevated.
Platelet was around 33.
Okay. So normally in liver disease, what will happen to APTT?
APTT will be normal.
APTT mostly it will be normal.
normal.
If APTT is also elevated, what else you suspect? PTNR is due to the liver disease. APTT normally it is not elevated in the liver disease at the terminal stages. All you can get it, but normally this patient is slightly elevated. Ours is 35, no? What is the
35,
normal?
30,
30.
35.
So slightly elevated, not very high. But what else you suspect? Suppose in that condition, like APTT also elevated. What else you suspect? What all things you can suspect? What else you suspect? Today also we are
DIC.
so one important thing should be like DIC. So the most important thing we have to suspect here is DIC. Okay. Any infection itself can increase the APTT. Severe sepsis can increase the APTT. But DIC should be always suspected in case of when PT is already elevated, APTT is elevated, platelets are low. What is the fibrinogen level here?
It's actually not.
Fibrinogen should have been done. Okay. What happens to fibrinogen in DIC?
Decreased.
Fibrinogen will be low. Okay. So what is the treatment difference, like difference in treatment between PTINR alone elevated, PTINR and APTT elevated and fibrinogen low? That is DIC. Okay. So if suppose it is only liver disease and PTINR is elevated, bleeding tendency is there, how do you treat?
We can start on vitamin K.
How do you treat? Vitamin K, is there any role?
No.
Strictly speaking, it has got no role. Okay, vitamin K is useful in obstructive jaundice where the vitamin K is not absorbed. But thinking that when there is a liver disease, there is a possibility of obstructive lesions in the liver, it can sometimes reduce the vitamin K. So you can give vitamin K. That doesn't mean that that is a treatment of choice. What is the treatment of choice? It is?
4-factor BCC or FFP.
Okay. FFP is the treatment of choice because 4-factor BCC is not available everywhere. So FFP can be given. What is the dose of FFP? Dose of FFP. Today morning I asked. Dose of FFP. You don't tell 2 pints, 3 pints, 4 pints. That's all. We write 4 pints. You have to tell me the dose of FFP. I'll give options 5 ml per kg, 15 ml per kg, 25 ml per kg, 50 ml per kg.
15 ml.
15 will be a reasonable middle way. So 15 ml per kg is the dose. Then you have to think about cryoprecipitate. Dose of cryoprecipitate?
10.
How many bags of FFP require 1 bag of cryoprecipitate? 10
kg.
1 vial, 1 FFP. Okay. So you should know the dose of FFP, you should know the dose of cryoprecipitate. Otherwise, we will be blindly treating the patient. Okay. And target fibrinogen? What is the target fibrinogen? Today morning I asked. Target fibrinogen. It should be kept above 150. So normally is 150. Panic level is less than 100. Should be kept above the normal level, kept above the normal level. Then only you can control the bleeding. Okay. Here, since there is a PTNR elevation, that may be due to liver disease itself. When the APTT is also elevated, it can be due to DIC, maybe due to sepsis or infection. We don't know. And fibrinogen is not done. We should do fibrinogen to know whether the patient is going for DIC or not. DIC treatment is different from FFP. Sorry, different from your liver disease. Liver disease, we only give FFP and like you told, vitamin K can be add on to the treatment. But other one, you have to add cryoprecipitate. Okay. What happened to the patient afterwards?
Afterwards, he was actually planned for decompressive
Craniotomy.
but actually it cannot be done because low platelet. And so not fit
So
for
what should be the platelet level in a patient when you are taking the patient for a neurosurgical procedure? So this is a very important scenario. We come across this scenario very often. What should be the platelet level when you are taking this patient for a craniotomy?
Greater than 80,000. 80,000. 1 lakh.
1 lakh is the level, advisable level. But if the patient is deteriorating, we'll have to do it fast. But if we can keep the level above 1 lakh, then the tendency of bleeding can be very much low. Okay, so we should achieve that. So FFP should be given, cryoprecipitate should be given, platelet should be given. Then this patient can be taken for procedure. Suppose the patient is coning, there is no other option, immediately you can take. Okay. Anything else?
So the repeat CT was done 24 hours later, and it was actually the bleed size was a little bit reduced, and no midline shift was noticed.
Okay.
So they was managing conservatively.
Midline shift will not happen here. Here actually the pressure increases, patient will cone. Okay, the patient may develop features of raised ICP. What are the features of raised ICP?
Patient will have headache,
Headache is already there.
vomiting is all.
Vomiting, then bradycardia is the most important one. So that's why whenever we admit this type of patients in ICU, we have to monitor only the heart rate. People anisocoria is more
dilated people are pinpoint.
dilated people will be a feature of like brain death. Pinpoint people can be there in the brainstem.
Usually pinpoint.
But anisocoria is the most important
Anisocoria.
finding. Carnohan sign. What is that? Carnohan sign. False localizing sign. What is that? Should learn all these things. False localizing sign will be a short note for you. False localizing neurological signs. Okay. But like you told, the most common finding will be anisocoria. Okay. Anything else? Okay. Thank you.
Thank you, sir.